Good morning, and welcome back to another round of our live peripheral interventions here at Mount Sinai Hospital of our endovascular program. I am Raman Sharma. This is Dr. Karthik Gujra.
Morning.
We are pleased to have all of you join us for another live case. It'll be another very interesting one. We look forward to just kind of also welcoming you for our subsequent live case coming in at the end of June. This time will be on the last Wednesday on June 29th. And most importantly, and Dr. Gresham will also be commenting more about this, but we really look forward to filling up your email inboxes with all of our blast notifications about our upcoming EVS Summit on October 6th, 7th, and 8th with a combined fellows course, aortic, and venous agenda. It'll be a really sensational program, just as it was last year, both live and in some hybrid event if necessary. And we really look forward to hosting all of you coming up this October. We're going to send it over to Dr. Krishnan, who is joined by Dr. Vishal Kapoor and Dr. Twinkle Singh. And we have another very, very interesting case today. So Dr. Krishnan, if you can, please take it away.
Yes, welcome Atul, Raman, and Karthik. So
Oh,
we've got a very incredible live case here that we were very lucky. We had initially planned on doing last month's live case, which was a CTO iliac that unfortunately had issues and couldn't come, and we did another case. But then we're lucky enough to find this wonderful patient who was willing to contribute to all our education by agreeing to be live. So let me introduce our team. Obviously, Dr. Kapoor, everyone knows, to my right. To his right, Dr. Singh. Behind me is Ray Lascano. And then we have Elizabeth, and I believe we have, who's our tech today?
Asif.
Asif.
Asif's our tech today. I didn't see him yet, so Asif is here. So we've got a wonderful case, so we're just going to jump right into it and get started. Twinkle?
Yeah.
just before you start, Twinkle, just wanted to also say I apologize, but one of our also moderators via Zoom is Dr. Atul Kokar, who's also joining us as well.
Okay. So patient is a 87-year-old female who presented with abdominal pain with food intake, resulting in severe food aversion and failure to thrive. Her past medical history is significant for 2 layers of stents in SMA artery, last being a drug-eluting stent done in December 2020, and she has a known occluded celiac artery as well. And IMA. Her exam is significant for cachectic and frail old female and a feeble radial pulse. So this was the last intervention in December. This was a previous stent that was done somewhere outside in order to have a stenosis, almost total occlusion or subtotal. And then we did a Resolute Onyx 5026 stent, and the final result is on the most right. So now, because of her symptoms, we obtained an ultrasound, and that showed that her SMA stent has increased velocity of up to 724 centimeters per second. This is a significant increase from January, previous ultrasound from January this year that showed velocity of 208. So this is the end of the presentation,
Yeah.
and we can show
So we're gonna go over the case, guys. So as you know, so she's a lady that we know very well. We followed her for a couple of years now since her stent, and she's been doing quite well. She's got classic abdominal angina, and food aversion now, where she doesn't want to eat. But she's actually has been tolerating this as much as she can, drinking Ensure and so on and so forth, but has had some subsequent weight loss that concerned her family. We put her in our surveillance program, which I think is very important. Obviously, the patency rates of these stents vary, with drug-eluting stents doing the best, but however, as you can see, not very well. So when we found that she had a failure to thrive, as Twinkle presented, we did the ultrasound. I think this is a very good opportunity because I think abdominal ultrasounds are very difficult to also, and I think Dr. Sharma Raman had a very good point, is that, hey, we're doing this as a live case, should we do a CTA? But we correlated it with her symptoms because she has significant return of her symptoms, and she had significant weight loss as well, and along with the elevated velocities, and a definite shift between January and here. So we decided to bring her in for the angio. So Vishal, can you talk a little bit about why we chose the groin and what we did? And Raman and Karthik, why don't you guys talk? Actually, before we go to Vishal, why don't you guys talk about how you would approach this patient?
Yes, sir. All right. Well, I mean, I think when we were first talking about the case, even last year, I remember when I was a part of this case, the first intervention that we had. The first question is this truly related to true mesenteric ischemia? I think one of the biggest problems that we see out in the field is that it's very easy to see people who have abdominal pain and they get an abdominal duplex, so some degree of celiac artery stenosis. But I think without really understanding what that singular, vessel stenosis means and setting of the SMA IMA being wide open, the first things first is make sure that what you're not really just looking at is just, it's like a median arcular syndrome, or maybe some even more benign as maybe it was just not phased correctly. Now that being said, I think one of the biggest things we always have to do is really ensure that the true mesenteric ischemia will really only happen in the setting of two of the other three being nearly occluded, and the third final one being also highly stenotic. And in her case, we do know that very, very well, that she does have a total celiac and I think subtotal or totaled IMA from the last angiogram. So she really was living off this singular SMA. And even at that, I mean, when we first saw her, I think the biggest clue is the classical food aversion, weight loss because of true symptomatic mesenteric ischemia, and she really fit the bill pretty well. I think duplex is a very reasonable place to start, followed by CTA if there's any question, if there's if there's any disagreement based off the duplex ultrasounds, because remember to get the steering appropriate in somebody who's larger is definitely very, very challenging given the air bubbles of the stomach and everything. But she was a small young female, so she didn't really have too much bowel gas to really have to get by. I think that's pretty much it.
Yeah.
Yeah, so I think that's great points. So what about access-wise? What would you guys choose? I mean, obviously we chose the groin. We'll talk about why we chose the groin. What would you guys choose?
I think in general for SMA stenosis, radial is a great access because of the way the takeoff of the SMA is.
Yeah.
I am not sure why we choose groin here. PK, I'm sure you have your reasons. I'm sure you have the reasons, but I preferably choose radial access for most of the SMA stenosis.
Yeah.
For celiac, usually we try to choose groin because of the way it takes off at a more 90-degree angle, but SMA is always more of an acute angle. So that's what I would prefer, and I would definitely reiterate on. I think here, I don't know, PK, I totally agree with you. Once you have a stent placed in SMA, I don't know if CAT scan is necessary. Usually, ultrasound can give you a very good velocity increase, and it can tell you exactly. Usually, if a native SMA stenosis is there, I would never probably go for a native SMA stenosis based on an ultrasound reading. I would definitely get a baseline CTA. Just to at least evaluate how the SMA takes off or is it just arcuate ligament injuries, and there are a lot of other nutcrackers. I mean, there are so many other reasons to think why ligament injuries can happen. So otherwise, here I think it's a pretty valid point.
Okay, so Vishal, why don't you comment?
So in this case, the reason we chose radial is, so she's had multiple interventions from the left side. The left radial is occluded. And last time when we were trying to do ulnar, she had like severe spasm. So small, petite person, severe spasm, requiring most likely a 7 French system, because we're trying to, our thought process we'll discuss is whether covered, non-covered, second layer, or just ballooning, which we'll talk about. Third layer, yes, ballooning, or I don't know, maybe off-label DCB, but we'll talk about that part. But the idea is, because of these 7 French axis, small, petite, occluded left radial, and spasm on the left ulnar, our goal was to, and ideally, like you said, the teaching is mainly going the left radial. So we in this case, we switched over to the femoral axis as our alternate bailout plan C strategy. So that's the goal. We're using our femoral axis in this case rather than a classic radial brachial axis.
Also a couple of things here before we get to Twinkle's presentation is, what is our goals of therapy here, right? So, I don't think cutting balloon is going to work, right? If the second layer of DS didn't work, cutting balloon is not going to work. We got to put in a covered stent. So covered stent, what are the choices? Well, we have obviously the both the BARD and the BD and the covered stent from Gore, which you can't remember the names, but which one?
The Viband.
No, not the Viband.
VBX.
The Gore Papaya.
the VBX and the Livestream.
Correct,
Both of those
Livestream,
stents we could use, but those are going to be obviously large, bulky stents. So we're going to need, we're going to need a bigger access from the radial or the brachial. We could have done a brachial cut down on the surgical guidance, but again, she's a little lady. We're very concerned about arm ischemia and stuff like that. So we decided to go with a tour guide, which for cardiologists who are watching is not really a very common catheter that you might use unless you're doing a lot of aneurysms. So Vishal is just going to kind of demonstrate this tour guide for us, tell us a little bit about it. We don't have a video on it, unfortunately, but Vishal, why don't you tell us a little bit about the tour guide?
So this is a guide which comes made by Medtronic. It's pretty much like a guide with a sheath built in. So it's a 7-friend system which is torqueable, and it torques pretty much all the way acutely in cases where you need better angulation. So normally, as a cardiologist, we use IMAs, anything to hook into the Simmons and all. But in this case, we need really angulation and mobility of the guide. So this guide provides us all the mobility and gives us the different angulations we have to engage in the system, especially the celiac where the takeoff is almost acutely on a downturn. So here you can see that if you try to torque it, so it has torqueability where it torques almost like 9 millimeters all the way down the range. So we try to hook up. So it's a sheath in itself, like I said, like any peripheral guide.
So what he's doing is basically torquing it down into it. We've got the pressure against the sheet. So when he's against the wall, we'll see the pressure. So he's scraping the wall there. Now we see he's turned it. And now what we're going to do is we're going to go ahead and torque it into this. Now remember, this does not mean you're going to deliver the stent. Let me tell you, this is just the beginning of the problem. Okay. But we're going to now just kind of engage it. So what we'll do is we're going to face it towards the stent, and then what we'll do is we'll decide whether we're there or not. You're just flushing. And
for everyone watching, not many people have gotten their hands dirty with this guide. As Dr. Kapoor was kind of angulating the tip of the guide down, you saw it. As you were mentioning, you saw the pressures dampening as you were becoming faced with the aortic wall. Would there be any utility of kind of using a similar technique as we do with engaging the renals, with keeping a wire in the sheath to avoid any damage to the aorta?
I agree with you. I mean, you mean like a no-touch technique? But the problem is,
it's already stented.
But this guide has to turn. So with the wire, it's going to have more difficulty and probably a little bit more resistance in turning. And it's such a soft tip. If you hold this wire, and we have our reps here, they're wonderful to come in early in the morning, and they've done a lot of aortas with this. And I was assured by our good colleagues that that this is something that's going to be pretty easy and benign as long as we're not the curve's already done.
Let's take a picture.
Yep. Oh yeah, you're in the vessel, right?
I know, but you want to take a DSA, no?
I think we have one, right?
Okay.
Yeah, I think we have one. But we'll just want you to do a roadmap. So what we'll do is we're just gonna put I want to IVUS this to understand whether we didn't expanded it, who knows? So we're just gonna go in with an 014 wire. Now, I just want to see.
PK, can I ask you a question if you don't mind?
Sure, please.
Let's say, we are Sinai, so we have everything available in our fingertips. But let's say most of the people might not have this equipment available in their hospitals. Is there any other guide you would choose if you didn't have this available? Any other guide you would choose from the femoral which would serve purpose like this, like a rim guide or anything else which is
you know what I would have probably done, Karthik? I would have probably gone with a Simmons catheter from above. And then with the Simmons catheter, I would have hooked it with the Simmons, and then I would have put an 035 wire down. I would have put like a super core down. Once I put a super core down, I just need a wet one. And then I would have gone ahead and tried to, track my sheath in. Again, see, this is not going to be easy, believe me. This is not an easy case because I know this tour guide looks sexy, but this one is not an easy one.
I think it's just the angulation, the way it sits.
Vishal was not happy.
This looks much better.
Yeah, but the question is, it's not sitting, as you can see. So I'm just going to try to pull it really in and hold negative on it.
Taking some of that deflection off, because SMA seems to kind of.
You think you're
We'll go to another view.
Yeah.
It just doesn't float very well, so it looks like it's in a small branch or something.
It probably is.
Or behind or in between the stent struts or something like that.
Yeah, I mean, so we're going to IVUS this to make sure we deal with it. We're in a small branch on the side. Yeah, this wire is not behaving the way I want it to.
Which wire did you
wire is this?
We went with a Sparta core, Karthik.
It lost the curve.
Yeah, it's lost the curve.
Let me read.
So let's redo the curve here, and I think what we're going to do is we wanted to IVUS it first to understand what's happening, and then we're going to go ahead and do it. So again, the other part is you have these wonderful 035 stents, but remember we also have wonderful 014 stents, which may be enough. So we actually called Biotronic and got a hold of the papyrus stent to use. And
But papyrus has a very high rate of stenosis, right? When compared to at
Well,
least the peripheral covered
PBX
stents.
and Vibons, yeah.
Well, I mean, again, the data is so variable on it, especially because of the usage in this case. I mean, you have to use covered stent. You already have 2 layers of stents, unless you're planning to do something else like a surgical intervention. From an endovascular, I think covered stent is their best strategy.
Guys.
Yeah.
Yeah, I'm gonna have to
we
use
can do a run
torque.
through if you
It's
want.
not
but-
torquing at all.
Yeah.
Yeah, so I mean, I agree with you, Karthik. I mean, our limitations are quite difficult here because what are we really going to do? I mean, we can't use laser for ISR. I mean, I'm sure it's probably had a case report somewhere where it's been done. What else can you possibly do? DCB? I mean,
It's a DES. I don't know if DCB is going to really
yeah,
make a
exactly.
difference.
In the gut is not really something that I would be very interested in. And so, it's sort of like Vishal and I really talked about this and Twinkle, and we sort of decided I cannot torque this wire for the life of me. It's interesting.
Give me a
That's
run through.
interesting.
Oh, let me.
I was, I think this is you're in a unique spot here because as
I have a
interventional
trailblazer I can run
cardiologist,
through if you want.
you're thinking let's really
Now it won't
debulk
go.
this ISR. Let's
That's right,
cut.
yeah.
There's some atherectomy, something, but unfortunately, there's not much that
There you go.
we can feel safely to do here.
There you go.
You see this in
Just
like
your
an
torque is not
LAD
undo
or a CIRC RCA. You're thinking
wire.
we'll do ROTA or something along that line. But would that be something you would even consider here?
Well,
Considering
no,
that
I
this
mean,
is
I mean,
our-
you're not. I mean, there's no way you're going to do any rota or anything like that here, right? Because obviously this is in the gut. This
Yeah.
is in the gut. You're not going to do that. So the idea here would be to get in and out safely. We felt and we spoke as a team that at this stage, cutting balloon is not going to work. Restenting with a covered stent may be our only option.
Yeah.
So what we're going to do is we're going to do an IVUS to make sure that we size the stents properly. And the IVUS is also going to teach us a lot in terms of how this thing behaves. If this thing behaves, it's very difficult to get the IVUS across, then there's no way I'm going to go with the Vibon or not a Vibon, a VBX or something like that. If I can go with something very simple, with a off-road map here, if the IVUS goes and makes a turn, then at least I feel a little bit more confident. But you see how it's not sitting well. So
I
this
think
is
you
gonna
might have to
be-
turn. You
Yeah,
might
this
have
is
to
gonna
turn
be an
once before
issue,
the IVUS
yeah.
goes in.
Let's just leave it like that a little bit. I'm just going to leave it a little parallel like that. Vishal's holding my wire here. See that? Look at this. Look at the difficulty of the IVUS. Look at this. See?
Oh, yeah.
See? So the IVUS is not even making a turn. So this teaches you a lot in terms of how it's happening. Vishal, just want to turn this, right?
Yeah.
But is that happening because of
That's
the tip of
the
the
angulation.
tour guide,
No,
or is
it's an
that
angulation
more-
on the guide. I think the guide
the
itself
guide
is
itself,
yeah.
not as
Yeah.
much as the actual.
I know,
stenosis
but
of
like
the-
no, but that's true. But that's what it makes sense. As PK is telling us now, what about the deliverability of a covered stent? Remember, it's a stiffer stent as well.
See,
So
look at
balloons
this.
and all might go in.
See, look at this. The IVUS is not even making a turn. Look at that. The
Let's
IVUS
go
is kicking me
slow,
out.
yeah.
And there's so much tension on this IVUS. It's unreal. So, yeah, this is not going to work. So
You
yeah,
think
so-
the wire is in the true
Behind?
lumen? Like
Mm-mm. The wire is definitely in the true lumen.
We can
Karthik.
try a balloon to really show you.
So what I'm going to do now is I'm going to keep this. I'm going to get an 035 wire because I don't think now anything is going to go. This is what I was an.
Over an 8
Let's
hours.
try an 014 IVUS here. So
and
I'm going to try.
PK question, like you didn't want to try a right radial?
Well, we have the opportunity to switch, Karthik. I just think in this particular case, the right radial, I believe, is also thrombosed, right, guys?
Right.
We
So
haven't-
again, the issue was big time spasm on a small lady. Right radial is again a possibility. Like PK said, we could approach brachial, cut down, percutaneous with a surgical make sure. But brachial has its own lot of complications associated with it.
So,
that's why.
we give it a shot here, and then we decide what's going to happen. And then if we have to convert to another
Yeah, we're
another
always open
access,
to
we
that.
will. But at this stage, we wanted to go with a larger covered stent, and hopefully we can do that. If not, we'll go with the papyrus and we'll balloon it. But again, if the IVUS is not crossing, the issue is going to be what are we really going to do here in terms of deliverability.
So,
if the IVUS doesn't cross, what I'm do is just balloon and then try to deliver my my covered stent.
Vishal and Raman, what and Atul, what VBX? I don't know what's the smallest VBX we have. It's 7.0 is the smallest, or we have 6.0
Yeah,
also?
7.0. We have a 6 and a
No,
7.
there are 5.0
5.0s
VBXs.
also.
There's
5.0?
5.0. There's 5.0 VBX, 6.0, yeah, and
I've never tried
7.0.
one, so I don't
We have all of them. So, we've also got the 5.0 papyrus. We've got the 4.0 papyrus, which goes into which becomes a 5.0. So, this is so acute. You see that? This is so acute.
Yeah,
There's
that
no
bend
chance.
that bend is a killer.
There's no chance. So give me a balloon. Let's see if a balloon goes first. Give me a 4.0 balloon here.
4.0 short.
Just give me a 4.0 short balloon. Let's see if a coronary balloon will track.
Give
If
me
a
a coronary.
coronary balloon doesn't track, then the question is whether we need to deep throat
coronary.
this via the thing.
4.0 NC.
Put an 035 wire down, and then coronary 4.0, please. Yep. And then we're going to go ahead and deep throat this with an 035 wire, maybe with a Simmons guide, and then track this over the Simmons across the stent and take a look.
Wonder if another option would be to go with a like a 7.0, like 7 French IM guide with a guide liner, and park it a little bit higher so that the distance of the curve is not as acute. You'll have the full turnaround, but at least you'll have less of an arch.
Right. I mean, look, I think the guideline is another thing. 100% we've got open in the back here. But let's see if how these things. I think we have to learn about the behavior of everything. Let's see how this behaves. If this behaves very difficult, then we have to deal with come up with different ideas. So everybody keep an eye on the balloon because the balloon crossed. Oh, good. So that's promising, right?
Please we're into
So now I'm
not behind the stent.
Now I'm just gonna pull this back a little bit, right, like that, and then. And we're hold it right there, Ray. And I'm just going to advance the balloon slightly, and we're going to go up right there, staying in the stent. Go up.
Going up.
Is this a cutting balloon or a scored balloon? Or
It's a regular NC right now.
Just a regular NC, Atul. That's a great question. With all the difficulty we've had,
10,
I didn't
12.
want to go with a cutting balloon here.
12.
14.
What
I
size
was
did you go
hoping
with?
to get, then I'd have more confidence other equipment would go.
I agree. I do agree with you. Down.
Hold on.
Okay.
I'm so surprised that the coronary balloon went and 014 IVUS didn't go.
Well, it's a very bulky
Stiffer.
device. I'm sure the Boston IVUS might track a little bit better, but now we need to make sure we are well seated before we pull this out. So I'm just going to seat it back and then pull the balloon out. Keep the balloon there while Vishal takes a picture.
Yeah, ready.
Okay, ready?
It's a 7 French guide and it didn't track.
Better.
Much better.
Much better.
So we definitely have expanded it. Now, the question is, do we change out for an 035 wire, or do we cut now with an angioscope that's a 5?
I think I would probably cut, give it a little bit of more luminal gain.
Yeah, I agree.
I'm thinking guide liner already. I'm thinking get a balloon
I
down
think
there.
this will track.
But so I agree with you, Atul. But the guide liner, the problem is so you're basically saying go with a coronary covered stent versus a peripheral covered stent here, right? Because a peripheral covered stent is not going to track.
It's not going to go through a
Yeah,
line.
Mike, is that an 018 or an 035 system, the peripheral covered stent? It's an 035 system, so it's quite bulky.
Yeah, definitely. Yeah.
And I don't think it's going to go. And the coronary covered stent might be the way to go. I mean, we're just asking people who use this. What do you think? The only other thing is to try to get a.
I don't think we can do a Vibon here.
No, I wouldn't risk a Vibon here.
No,
Definitely not.
Vibon
VBX
compression is like I would not use a
Yeah,
Vibon.
5.0 angioscope.
I would either use a VBX. I think Paparas is if you can make
cutting balloon.
if you can make the Paparas like larger than 4.0, I think it's pretty reasonable to try Paparas.
Hold this.
Yeah. I mean, that's the whole idea. I mean, the idea is to try
then
to
it's
see
easy.
sort of,
Then you can put a guide liner across and then use the Paparas.
yeah.
But it's not calcified though.
Yeah, exactly. I mean, the plan is to try to get as much luminal gain as we have. It's
There's
too
a
layers.
question about shockwave, and I think it's not calcified. I don't think this is. I think this is just ISR.
Yeah.
I think this is clearly just ISR. The only question here is why not put a catheter through, and then put an 035 wire down, and then try to track what is it called, a VBX. But the question is, are you getting any advantage over the VBX versus the Papyrus? So my logic is, if you think about it, you've already got the struts of 2 stents there. So I don't think the crush is going to be an issue. And these stents aren't crushed; it's just restenosed. So I don't. I think the added value of a VBS doesn't help here. So I think we'll go with this. But before that, while we get there, while we cut, why don't we have Twinkle present the mesenteric presentation that she's kindly prepared? Foro.
Okay.
Yeah.
So just going over epidemiology of chronic mesenteric ischemia, incidence of symptomatic disease occurs in almost 1 in 100,000 of general population. It requires stenosis or occlusion of at least 2 out of 3 visceral arteries. More common in women in age of 50 to 60 years. And because there is so much collateralization, it rarely gives symptoms. Like it gets symptom only when there is significant stenosis of at least 2 of those arteries. Okay. So most common is atherosclerosis, and that usually occurs within 2 to 2.5 centimeter of the ostium. Okay, and just going over a little bit of anatomy, this superior mesenteric artery, it supplies the entire small intestine except the proximal part of duodenum. Is jejunal and ileal branches that you see, they supply jejunum and ileum, and ileocolic artery supplies distal ileum, cecum, and proximal ascending colon. And right colic artery supplies blood to the mid to distal ascending colon. So the first branch of the SMA, inferior pancreatico-duodenal artery, then middle colic artery, then right colic, and then it terminates as ileocolic artery. The collateralization between SMA and IMA occurs by the main thing is this marginal artery of Drummond, which runs the entire arc of the colon, and the second is arc of Riolin, and Riolin that you're seeing is connects SMA to IMA. And the celiac artery, it supplies liver and spleen, as we know. Okay, so going with the causes of CMI, atherosclerosis is the most common, but there are known atherosclerotic entities as well. Mainly fibromuscular dysplasia, median arcuate ligament syndrome is well known, neurofibromatosis, or even vasculitis and post-radiation stenosis, retroperitoneal fibrosis, entities like that can cause. It presents most commonly as postprandial angina, extreme aversion to food, weight loss, bloating, diarrhea, and some just non-specific GI symptoms can happen. Usually the diagnostics, duplex ultrasonography is the first test, then CT angiography or MR angiography can be used to confirm. Okay, so on duplex, the celiac artery, the number defined is 275. So PSV of more than 275 at the ostium of celiac artery is suggestive of critical stenosis. The celiac artery vascular bed is a very low resistance. So the waveform at the celiac artery will look like a biphasic waveform with no reversal of flow, and will have high end diastolic volume because of the low resistance vascular bed. On the SMA, on the other hand, is in the fasting stage. It is a high resistance, so you will see a triphasic waveform, no end diastolic velocity, and some flow reversal. In the postprandial phase, it becomes a slightly low resistance vascular bed, which presents as biphasic waveform with the defined peak systolic velocity for SMA is more than 200. So there's more than 200 centimeter per second that suggests of more than 70% SMA stenosis. Okay, so arcuate ligament syndrome, whenever we see increased velocity at celiac or SMA, ligament syndrome has to be ruled out. So that essentially means the compression of celiac artery by median arcuate ligament that occurs when patient take a deep inspiration and downward movement of the diaphragm compressing the celiac artery. So, duplex is a good way to see if it's an arcuate ligament syndrome, because as soon as the patient take a deep breath, you will and the compression of the celiac artery happens, you will see increase in the inspiratory velocities, and that will decrease in expiration. So conservative management has very little role, mainly including control of risk factors, smoking cessation, avoid any increase in the intestinal demand like large meals. Vasodilator agents such as oral nitrates can be tried, nutritional assessment and management. So the revascularization it can be either percutaneous endovascular or open surgical revascularization. Open surgical revascular used to be the gold standard until 1980s when the endovascular treatment of SMA was first done. So going over the open revascularization, one of the studies was done by Kihara et al. Involving 42 patients and 66 arteries. They showed a 30-day mortality of 10%, and but a 3-year and a 5-year survival rate of 65 and 70%. And CAD and CKD were independent risk factors in their study for occlusion. Another study by Park et al. It's for open revascularization involved 98 patients. So they followed those patients up to 10 years, and 79 patients underwent multi-vessel reconstruction. That study showed a 5% in hospital mortality, and almost all the patients that died were more than 70 years old. Their 1-year, 5-year, and 8-year survival rates were 83, 63, and 55%. And their 5-year symptom-free survival rate was 92%. There was no difference between antegrade or retrograde surgical approach, and there was no difference between single vessel or multi-vessel reconstruction. Another surgical, so there is no randomized data, but all these like long follow-up. Another study including 54 patients with 56 lesions also showed a high mortality, a high morbidity, but good patency rate long term. So essentially, just the main points of the open surgical revascularization, that it does carry a significant morbidity and mortality ranging from anywhere between 5 to 30%. But long term, the patients who do survive, they have very durable results. So it will not be suitable for malnourished and older people, as they are more subjected to high morbidity and mortality in the peri-operative period. And patients with CKD, CAD, CKD patients who more than 70 years old are definitely at much more enhanced risks of high morbidity. So percutaneous endovascular treatment was first attempted for SMA in 1980s. Currently, it's a class 1B recommendation by ACC and AHA. Again, I couldn't find any randomized data. So one of the studies in 2010 by Gibbons et al. Showed 76 patients who underwent 101 procedures. Their perioperative 101 procedures, 49 patients underwent PTA and 52% patients had bypass. So it was PTA only and there was no stent. But perioperative morbidity, as expected, was higher for bypass versus PTA, 32% versus 6%. 30-day mortality also higher for bypass as expected. But 1-year and 5-year survival rate were higher for bypass, 85%, and primary patency rate was higher for bypass as well. Another study by Abu Rahman et al., including 83 patients over 10 years, they did 54 SMA stents. Where this is endovascular treatment, and they have a very high technical success rate of 97, but their 30-day mortality in this particular study was 2%. So it's a fair. In 2007, these guys they did a meta-analysis of almost 20 studies of endovascular restenosis, and they had a total of not 20, sorry, less than 20, but they had a total patient of 328 patients. They showed that their technical success was 91%. Just focusing on the last line, the complication rates according to this meta is 9%, and the restenosis rate is 28%, which is consistent with other studies. So most recently, there was another meta-analysis of 20 studies, 19 retrospectives, one prospective, having including patients, 11,000 patients, and majority of these patients are men and older than 65 years. There significantly less death rates in endovascular group was noted, and there was no significant difference in long-term survival between endovascular and open surgical group. And as expected, restenosis rate was significantly better for open revascularization, but vascular complications less for the endovascular group. So essentially, what we know as of now is that with endovascular treatment, there is high initial success rate, but less complication and less short-term mortality. A similar long-term survival and restenosis is significantly high with endovascular treatment, but this is with PTA and the prior generation stents. But now we have newer stents and newer techniques, so hopefully with endovascular treatment, the restenosis rate would be lower. This thing much more recently in September 2021. This is just a prospective follow-up of 86 patients among 35 patients with chronic mesenteric ischemia underwent 96 stents implanted, and among those 96, 86 were covered stents. At 2 years, their overall primary patency with covered stents was 76% and secondary patency is 95%, and restenosis rate of 14% with at 15 months follow-up. This is with covered stents. Okay. Another comparison of covered stents versus bare metal stents for chronic mesenteric ischemia involved 225 patients, mean follow-up of up to 29 months, and they also showed a higher freedom of restenosis, 89 versus 49% at with covered stents at median follow-up 24 months. So in the same study, covered stents had better primary patency at 3 years, 92 versus 52%, and they had higher freedom from re-intervention, 91% versus 56% at 5-year follow-up. So summarizing about from what we know from the data is, I mean, the CMI expedited workup is necessary, including a CTA, exclude any other potential causes like arcuate ligament injury. Treatment does require revascularization, and primary target hopefully being the superior mesenteric artery, as celiac artery has many proximal branches, and IMA only supplies less of the gut. Endovascular revascularization with the balloon expandable covered intraluminal stent is better compared to bare metal stents alone and is the recommended initial treatment. Patients with recurrent symptoms after revascularization should be treated with endovascular first approach, similar to the de novo lesions. And open repair should be reserved for selected younger patients and those who are either not endovascular candidates or who are at a very less risk of perioperative morbidity and mortality. So the tour guide that we used, I mean, we will show it at the end of the case as well, but it is available in 5, 7, and 8.5 French inner diameters at 45, 55, and 90 centimeter length. It has a very steerable distal end, and yeah, and we'll show the tour guide after the case is completed. So thank you.
Okay, so we did some cutting. We have, you know, we're now just gonna check distally because we look like on our 2 pictures that we took, we're not very happy with the flow. So the question is, do we embolize plaque material down into the IMA or the SMA? I hope not, but we'll take a look. So we're now going in. We had 2 wires in.
014.
And 2 014 wires, and now we're just going to go with an 018 Trailblazer
It's
and
an
take a
014.
look.
Give me an 018, brother. I have an
Is
014.
014? That's
Yeah.
fine. Whatever
This
it
is
is, it
over-
is. Let's just get
this is
some
over-
pictures and see.
Yeah.
Meantime, can you play the IVUS, guys?
That's just a color.
Okay, there it goes.
Yeah.
Okay, let's take a picture from here. Pull the wire. Actually, let me go a little bit
Yeah,
distal.
yeah.
Okay, pull the wire out now.
Hold on.
Uh-huh.
And PK, do you give any vasoactive drugs down there? Any,
Yeah, that's
Well, we're just gonna first let's see whether we're just not. We're getting blood back, so that's a good
Oh,
sign.
yeah.
And we're gonna take a decision. I mean, sometimes you open it, you're not fully engaged, and you know how that is. Sometimes we just don't see very well. Just want to make sure we don't have any embolized material down there, which would then make this even more interesting. So
This is contrast, right there?
okay, so we got some contrast. So we're just gonna inject distal here, just to make sure. Ready?
Okay, ready when you are.
Okay, so
Yeah,
we do
yeah,
have
we have
flow.
flow.
we're
Yep.
still seeing the IVUS frozen in.
Can we
Yeah.
put up the angiogram that you just
Yeah.
did?
We will. Yeah, that looks okay. Just a lot of competitive flow. It looks okay. So what we're
Can
gonna do?
Can we
Yeah.
switch to
Do you want to see the yeah? Let me show you the angiograms.
No,
real
I
quick.
think our screen is
Yeah,
freezed on the
we still have
IVUS.
the IVUS.
Yeah. Can you show? Yep,
Yeah.
there
Yeah.
you go.
So let me show you the.
See, there seems to be a little bit of slow flow there. You notice?
Hmm.
So this is the balloon we use. The cutter, first a 4O NC and then a 5O cutter angiosculpt.
And I always worry with cutting balloons. There's always some debris that might be liberated.
Hmm.
But right now,
So
you can
this
see
is
in
the
this
picture.
picture. Well, there's flow. There's flow. There's definitely flow.
Yeah.
Yeah, I'm just.
I
getting
think
a
the
little-
guide is just not completely
Exactly.
engaged.
Correct.
Yeah.
I think
It's
it's
engaging
the
the lumbar
more flow is
collateral.
into the aorta than actually the SMA.
Correct.
That's
I
probably
agree,
the
bro.
reason.
I
probably.
agree. So we're gonna
Let's
walk
put the
this. We're
wire-
gonna put the wire back down. So we
It's
have.
a huge
we're gonna,
vessel. I don't
new,
see a reason why it
This is
should
has damaged
Well,
it.
you know, we're
Get in
manipulating
this,
it. We're
Spartacle?
cutting it.
Yeah.
So now we have 2 wires down, and now get us another Spartacore, please. We're gonna put 2 Spartacores down. I'm gonna try to go with a VBX here,
Yeah.
just because the IVUS did cross after we had 2 wires down. So I'm gonna try to go with a VBX, and it's an 035 system. So I'm gonna try to put that on a 2 014 wires to give it an 028 system, and try to advance it over it. Then
Right.
once I advance it over it, I think the additional radial strength will definitely help us to be able to, keep this open. And again, IVUS sizing wise, we're correct at a 5, right? Guys?
Yeah.
IVUS wise,
4.7.
we're at a 5?
Yeah. 5.35.
5.3, okay.
4. So Karthik, you're absolutely right.
Did you
I
make
mean,
a C loop?
yeah.
Okay, good. Good.
The reason PK was concerned is the main thing is you're right. There's so much collateralization with different branches that trying to embolize and maybe closing one branch off is the reason. But if you don't see any flow, the biggest concern he had was when we were cutting it, did we have a distal dissection?
Did we have a
with the
distal
shuttle vessel?
dissection? Makes sense.
Correct. That's
Yeah,
more of a concern
honestly,
than an
we
embolization.
never came out of the stent,
Yeah,
but you
I
never
don't
know.
think so. Yeah, it's a huge
No, no,
vessel,
no.
PK. It's like
Yeah.
it's a pretty big vessel. So
Yeah. I'm just going to try to manipulate this into this to try to give
Hook
us.
it in, right.
It's not quite getting in. So let's see.
You guys like to
hold
use
the
any
wire.
nitrates, calcium channel blockers in these cases? Do you see a lot of spasm or microvasodilation in the gut?
We just pull
I know. I'm just trying to. I'm
Yeah.
sorry, Atul. I'm just trying to just engage this better.
the stent.
I don't know, Atul. I mean, if especially if you have one SMA
not
like
going.
that, which has really become large in size, because I think that's the only vessel which is left for the gut. And it's a lot of branches. I don't know if that much amount of
much tension, huh?
embolization will happen.
Exactly.
Let's try the stent first.
Yeah.
Give
Let me
us the
talk
stent.
around.
Yeah, we might not need complete engagement, PK. We might be able to
correct.
get it in.
You're gonna load it on both wires.
Really, the tough part is getting it over
Yeah,
the
yeah,
hook.
yeah.
You know.
Yeah.
I
that's
think
the
it's
biggest-
getting into the stent might not be a problem. I think, as Raman said, the biggest trouble will be getting across that bend.
Yeah, but I like the idea
Yeah.
of the 2
Two
014
014
wires.
wires.
Yeah.
Well, remember the guideline is not going to work here for this
529.
particular stent, so I didn't go with the guideliner because obviously there's a 7 French stent,
a
and
529.
so I figured that it's very flexible. What is that?
529.
The papyrus. We have the
Yes.
papyrus ready just in case. So let's try to go with this. Let's see whether I'm just not happy with my
Yeah,
tour
the
guide
way
right
it pushes back.
now. The tour guide is not in a good position here,
That's pretty good.
but I'm not
Fine
getting
there.
it. I'm
Coaxial.
not getting into the stent the way I did before. That's what's kind of bothering me.
Yeah, it's just being coaxial.
There you go.
Uh,
A little bit better, I think. Let's
It almost
try
looks
that.
as
Let me
if you
change the
lost
angle
a
for a
little bit
second.
of your angulation.
Angulation.
Yeah.
Looks like it
Let
may
me
have
try.
opened up
Ooh.
a little bit, so the other way. Yeah.
Yeah, and maybe opening it up a little higher with the wire further down will let you get a stent around
That's
the
better.
bend.
This is
Yeah,
good.
hold it there, guys.
Yeah.
And then
All right,
I think
hold
I
both wires.
Yeah, I have.
Fear
I think
that
it
may
to
be working
pull the whole
against you
system
here.
down.
Okay, we're going on 2 wires here.
Interesting to see VBX go across it. VBX is bulkier when
And
compared
you
to
with
a
the
coronary.
529, you said?
Yeah,
Yeah.
it's a 5029. Hallelujah.
Reasonable.
Almost there.
It's like push and
You
pull.
see, it's very interesting how you see the manipulation of the guide even opening up as this.
My
stent is
only
going
worry is I
through.
don't want to strip this VBX.
Yeah. Now
You
maybe
know?
just keep it disengaged. Let it
Yeah,
pop out.
exactly. Go a little bit free.
Yeah. Exactly.
Freely
So it'll be more
engaged. You can
coaxial.
open up some of the loop a little bit more.
Yeah. Exactly.
No, it's not going.
Hold on.
Okay, pull it back.
Yeah.
Okay, walk it out. It's not going. Yeah. So the problem
I
is
would
that
probably
I don't want to
just-
strip it. I mean,
PK,
you
I would
agree?
probably just use a, yeah, I agree. I would probably
Papyrus.
just use a guide liner, put it across, put a papyrus, and get it
No,
done with.
the one thing
No,
I'm going to
got-
do now is put an 035, what is it called, Navicross, and try to engage my guide liner a little bit better. Let me get a Navicross here, guys. Because I was close. Well, not that I was far away. A Navicross, guys, 035.
That's 29.
PK, what if you take the
Looks big.
your Toro guide and open it up and try to get the stent around it higher up in the aorta, and then reform your angulation of your guide to point it down so you get the stent out,
Yeah.
and then you turn it down to allow you to deliver it properly.
The
I know that
problem,
may
I agree with you, Atul, but the problem what I was having was that
Pushing
I
the
had
whole
so much
system.
tension in my fingers
Twinkle,
that I
twinkle,
did not
twinkle.
want to strip this stent.
Yeah.
So if I strip it, like we're gonna check the integrity of the stent now, make sure the stent integrity is still good, and if it's still good, then I'm gonna try to deep throat my guide liner, my tour guide in, and then try to get a better position of it, and then allow the VBX to make the turn, which I think I've been hesitant to do that because I've not been able to get into the stent properly. So now I'm going to use this to act like a dilator to be able to turn the tour guide in to the stent. So let's just
PK,
watch
you don't think putting an 035 wire will help?
I may do that. Let me just see how this feels,
Yeah,
right? I
because
mean, there's so much
so
there's so much tension, Karthik. I mean, that's the problem. See, I'm worried about the tension. See, look at that. See, this is not even entering. There's an 035 system. It's not even entering. See that? I'm
Probably not.
destroying the stent. See
I
that?
think it's not coaxial.
See, it's not coaxial. See that? That's the problem. And
Now, see.
maybe both the wires aren't coaxial. So pull out the other wire. Pull out the run through.
Hold on.
Yep. Let's see. Maybe the run through is not in a coaxial situation.
Yeah. Probably deflecting it off. Okay.
No, the problem.
Yep. Pull
Yeah.
out the run through.
Yeah.
So let
Run
me,
through coming. Yeah.
can you hold this one?
Yeah.
Oh.
Hold. One second. Go. Hold. Pull.
Okay.
Pull
Good.
your run through.
Now let's see.
Right there.
Yep. See, the run through might have been through the strut. This is interesting. Mag it up, guys, for me.
Mm-hmm.
But the Ivis went without a problem. I think it may be the bend, maybe. I'm definitely in the stent here, guys. All right, this is an angle trailblazer.
Navicross.
Okay,
Looks like so.
give me a straight trailblazer. 035. Yeah, walk that out, Vishal.
I'm just concerned about the stents right up there.
it's all right. You want to put a
Yeah,
covered
cover it
stent, so
anyway,
it should be okay.
No, but you don't want to.
In the IVUS, when we were pulling back, the most proximal part of the stent, did we see both wires in there, in the true lumen?
Run the Ivis again, guys.
I wonder if perhaps maybe one of the two wires was.
No, the Spartak or the first
thing.
wire was always, that's the initial work wire. So we didn't even exchange
That's
that
why
right
I didn't
out.
pull out that wire. I pulled
The
out
run-
the other wire.
The run through was the secondary wire,
Go
but
with
the
the
Ivis had
trailblazer,
no
please.
issue going in. So I don't think
And this IVUS was done with one wire in or two?
One.
one with the other one was with the buddy.
Hmm.
No, man, it's an 014 Ivis, so just one wire with the. But the other wire was like a buddy support system.
This is straight, right?
But it was
Yes.
in the SMA at the time.
Correct.
or not?
Yeah.
Mhm.
Should be fine. I think we'll be able to get it.
I think it's just the angle. Yeah.
It's just the wire bias, the angulation, and everything. So it's all right.
Same problem.
See the way the wire is. Yeah, no. No.
Oh.
Wow.
Same problem. Okay, give me a balloon, guys. I'm gonna need to balloon the ostium. Give me a 5-0 balloon.
NC.
NC. Yep.
Yeah.
Short.
Coronary. Give me a coronary NC.
Vishal, you want to take a whiff and see what's happening there?
Yeah, I'm just trying to
Make sure.
Yeah. I just want to see the stent starts with the manipulation of the guy. Sometimes the proximal
Ready?
part of the stent. Yeah.
I mean, there's some stent compression. You can see.
Yeah,
it,
that's what I'm looking at.
but I think it's still okay.
Yeah, it's just the way. See how the proximal part of the stent is a little bit more. We'll just balloon it.
I'm not at all engaged in this at
Yeah.
all.
PK, you think there is thrombus there at the distal edge of the stent?
No, it's an overlap.
It's overlap.
I don't know. There is some opacity which I don't like. So I don't know if it's just a filling of the guy or.
Well, our ACT is quite high right now.
ACT.
I mean, the ACT can be high, but still, I'm saying, I just don't know how that. I see some opacity. I'm sure it's nothing, but I just want to understand it's okay.
But the problem is I'm not there. That may be engaged. Yeah, there's no flow. I don't know. We checked there is flow, but
Yeah,
there it is. Ready?
Yeah.
There is.
There you go. There's no
There's
promise. Okay.
So I think we
This
just
looks
keep it
like a
that.
good guide. This looks
is
like
a-
a good guide spot.
Yeah.
I agree.
You might want to try the 035 now.
512, fine. Whatever you
Give
have.
me the 035 now.
035 now. This is a good guide spot. I think it's just
Open
the
a
way
wire.
that it's engaged.
Yeah, 035 Trailblazer.
Trailblazer. Okay.
Well, at least we know there's no thrombus, so Liz is breathing easy. So at least we got that out of the way. So what's our ACT, guys? Let's stay on top of our ACT. Yep, I might need 2,000 of heparin in
15.
a second. Okay.
5 is fine.
I need a real rail, guys.
Yeah, give me 1 second.
Yeah, I'm gonna
One
put
second, one
negative on.
second, go.
Okay. Okay, a real rail. Yep,
Yeah,
that's
real
good right
rail.
there. Let's just keep the guide engaged.
If the real rail is coming up. Go, baby. Go, 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 go. I think it's just the
That's it.
coaxiality.
It's
of
just
the
the
guy.
coaxial
yeah.
movement of the guide.
Okay.
That's it.
Now give us an 035 wire.
Super cool.
Supercore
Actually,
probably.
yep,
the
put a
safest
supercore.
of-
Put a supercore in, and then let's try to track this over this.
Yeah.
Deep throat
Laura?
it. Pull it out. Yeah.
Pull it up. Good.
Get a supercore in now. So remember, she may have pain with the supercore because you're going to now make this very acute, and you're going to have a lot of tension in the system. So understand that as well. So it may or may not work. But you don't have to get the
Also a
super.
pretty tight bend for the supercore to make.
Let's see. Let's see.
Yeah.
No, Raman's right. Raman's. You got to be careful. You don't want to kick the whole thing out.
Yeah.
Nope. Not going to go.
Want to keep a forward tension on the super
Yeah, got it,
catheter, just to be careful.
We have it forward tension here. A lot of tension, boy.
Yeah.
Okay, take it out. I don't
That's
like it.
pretty good.
No, but the soft end is still right there.
The
That's what
soft
we
end is
discussed.
still right there, right?
Let me
Vijay?
see if I can engage. Hold on.
Sometimes in this case, probably an amplats would probably work better because we don't have distance or length for the supercore.
I think that's wherever you are is fine, PK. I think it's okay.
Yeah, but we don't have
I
enough.
would not change the angulation right now, so I think it's fine. It's just matter of few minutes, right?
The problem is
actually
the tension
like
on the guy,
original-
guys.
Yeah. I actually like the original idea of the 2-0-4 wires at
Try the
this
201
point.
force. Try the 201 force. Take the supercore out.
That's
Or,
Try
so,
the
or,
two-
or
try-
what you could do is
Give me
do
the 201 force.
you could do a 1 V18 and 1 014. That'll give you beautiful support
Run through.
because V18 is a very good wire to give you support as well.
yeah, that's also a.
Why is it dye staining on the back?
That's not dye.
Oh, is this?
That's
she
the
has-
kidney. That's the kidney. Yeah.
Floor. So that's the run through first going in.
The other way. I'll make it go down. There you go. Next one.
All right. You want the Spartacore?
Spartacore.
Can I get a new Spartacore?
At this
Yeah.
point, is there any
have it?
way for you to,
I mean,
to
this is
track
the
This is
the
it?
tour
Oh, hold on.
guide
this
over
is it,
your
but I'm giving you
navicross, or
needle
is it
I'm
still
introduces
that same
because
amount of
the tip
resistance you're
is
getting from
I'm
before?
trying.
One
It's
second.
not
I have
exactly
it.
working for me. I'm not happy with it.
What if, what about changing the angulation at this point? Because
I
perhaps
I
No, no.
maybe that's also working
I
against you.
tried twice. Let
I
me
think
try
this is a
again.
better. So I don't want to
I'm
change
as
it.
angled as I can be with this
No,
navicross
don't
right
change.
now.
Don't change. Don't change.
Yep, that's it.
That's a good
Yeah,
spot
that
you're
was
in,
good.
DK. That's a nice spot you're
Yeah.
in.
I just worry about how the stent is going to behave making the bend. Nope, it's not going. See there it goes. Okay.
Wow.
A lot of tension.
Yeah.
Believe me, the feeling in our hands is incredible right now. The tension that we're feeling. Walk this out. I'm going to hold some positive
Yeah.
on the. Okay.
Yeah, so far, this is looking
Wow.
promising as long as
No,
this
no, no.
stays
It's a
the
lot of
case.
PK. So right when you feel it.
Yeah.
The
The question I think
especially
just comes down to again is how much of this is because of a proximal stenosis versus the angulation into the SMA versus the guide itself.
no, we did the IVUS. So once we run the IVUS, we'll show you. I mean, there is some
Yeah.
neo-atherosclerotic changes, but itself, it's not as if it's like pinched at the ostium because we did inflate.
What are we using now?
We're trying the VBX.
Okay.
try the VPX.
So yeah, we did balloon it first with the 4.0 NC.
Actually, let's balloon it with this 4.0 balloon again.
This is 5.
Give us a 5.0 balloon. I want to balloon it one
This
more
is
time
5.0.
with the ostium. ACT, Liz. Go. Just go on any one wire.
I'm gonna go Spartaco.
Okay.
You think the proximal stenosis is the issue?
I
here,
don't know.
guys?
I don't know,
Yeah.
Karthik.
I don't
I
know,
don't want to
Because
go
looks
in.
like once you engaged it well, the 035 catheter went through. So if the 035 catheter
Hold
can
the
go
wire.
through, I think the stent will go through too.
No,
So
hold
I
the
just
phone.
really
Run
just
through.
want to go
Oh.
make sure that we don't have any
Yeah.
obstruction when I go with the VBX.
Correct.
And if that doesn't work, then I'm just going to go with the papyrus and be done
yeah,
with the
that's
case.
probably better.
You know, I think the VBS is good. ACT is good, so we got a good ACT. You know, this is an issue here with this. So I'm going to fix both wires. And Ray's got my guide. I'm just going to go in. This is an 014 coronary balloon, so that may be the way to go.
Interesting.
Okay, let's see. Oh, it's twisting. There you go. Thank you, Karthik. Again, twisting. So you guys fix the wires for me. I'll fix the
I
guide.
have the wire.
I can tell you there's no chance the VBX is going.
Yeah.
There's absolutely no chance. There's absolutely no chance. Hold it there. Just hold it like that. Let's just balloon this open. But I'm not even going to go with the VBX, guys.
Yeah. So we use a guideliner, just park it in, get the papyrus down.
Okay.
Yeah, because the papyrus can strip. So get us a 6.0 guideliner, guys. Down.
I want to track it.
Okay, go up now. Okay, down. Okay.
Track it over? No.
Gonna try.
I want it's inflated.
Not going.
Wow.
I would not even.
Okay,
I
then
think if
forget
it's
about it.
if you're putting a guideliner, I don't think it matters anymore.
I
So
agree. I agree.
Okay.
there's no reason to push yourself to. Don't hurt your hands.
So tight, man.
I'm sure your fingers
You
are
want to use
already
a
like
7.0 guideliner?
aching right now.
It's a 706.
This is the case for the
give us
day
a
for
7.0
PK. No more
guideliner then.
cases
You have a
for
7.0
PK today.
guideliner?
I've
7.0.
I still.
Yeah, we have a
do-
7.0
do,
system.
Do
I
you
wanna do
think,
this.
as even Dr. Gura was even mentioning earlier, what about trying just to get the stent past a more open tip of the tour guide, and then
No, but-
angulating everything down?
I agree. I agree. That's what I agree with you. That is
Your
something.
wires, your wires.
The point is though is that you need to have the wire to give you enough support to be able to make that turn. So I think this is a smarter idea: is tracking the guideline at distal, then having a guide extension, and then going through the guideliner into our stent would be the first smart idea. Would be the right thing to do. Then if that doesn't work, then we try that. We know now the VBX is not going to make it because even the 014 wire had so much tension on it that I'm not going to try with the VBX. You know, and I think I think from the arm it's an issue, and we're not able to track it all the way down. So,
Fix my wires.
you know, I think this is what we got to do. Let's see.
Last time when we did this, we went from the radial.
Yep.
Is that correct?
Yeah.
Yeah, and the radial's gone now. Yep. The question is getting the radial, these wires a little further down. A little worried about spasm. And let's see. Let's see how the guideliner behaves. Obviously, this is a much more elegant way of doing things. I think we have to balloon track the guideliner.
Balloon track the guideliner. Yeah, yeah.
It's amazing.
I think it's just the angulation, Vishal. I don't think it's anything
yeah,
to
no,
do
you're
with
right.
the stenosis or anything. It's just the stent struts. There are 2 layers of stents, probably not completely
pull that
covered on each
run-through out.
other.
Put the run through on. Let's balloon track it.
To give you a little bit of a wire bias
Yeah,
out.
just balloon track it. It's like we do in
Hold on,
coronaries. It's easy. If you're using Paparis, straight up.
Okay, I'm gonna pull the run-through out.
Okay, we're gonna try to balloon track it now with this.
4 balloon.
See if it goes now.
It's not going.
You want a 2 balloon?
Yeah,
You want 2
any 4 balloon.
4 balloon is fine.
Yeah, anything to track.
Any balloon is fine. Doesn't matter.
No, not going.
Okay, that's fine. Okay.
So we're using what size of stent for Paparis, PK?
6. We have a 5.0 that we're gonna post dilate to a 6.
And it'll go through a 6 French guideliner?
Yes.
Yeah.
Okay.
We have a 7 French
7
guideliner.
French guideliner.
Oh, so
We have a 7 French.
Yeah, we have a 7 French guideliner.
Yeah. Yeah. Okay. No, we're good. We did.
Have you guys giving any nitro down there or any verapamil?
Not yet, buddy.
Oh yeah. Yeah, well, we just made it to track it.
And now we're going with both here.
Maybe more distally in the tracker.
yeah, you can go a little bit distally. I mean, your stent is going to come out of the other stent anyways.
Correct.
Let's just get into the stent
Balloon?
properly.
Yeah.
Go up.
Right
I just want to enter
2.
properly.
Let's go 2.
Okay, I'm going to fix the sheet, Vishal, you track.
Yeah.
I'm just going to fix the sheet for Vishal, and then Vishal is going to track
Okay, balloon down.
all the way down.
That's it.
There you go. Okay, good. All right, good.
That's
All
good
right,
enough.
Yeah, now give us the Paparis, guys. Yeah,
What's the
What-
length?
What's the length?
26. We have a 26. We have a 26.
We need a 26. We need to.
Is that the longest one we have? Mike, is Mike around? Would this one go through a guideline or no? Right?
No, VBX will not go through
VBX will not go
guideline.
through.
No.
No way.
All right, guys, give me the Paparis now.
As long as you cover the ostium, it's fine, PK. And then you can always put a DES necessary if necessary below. But
Yeah, I think we have adequate length to
uh,
really do it.
I don't know, 26 will mark it. We'll
Well,
see.
the stent is what, a 22? What's the length of the stent? First stent we put in.
Looks like it's around 20, 26,
20.
27.
What was the stent we put in, guys?
That was a Resolute they put
Maybe
in.
extend cost.
Yeah, Onyx Resolute. Yeah.
18 or 24. There's
Yeah.
2 layers there.
26.
Yeah.
The previous was 26 length.
26 length.
26,
Yeah,
five,
it looks like
26.
26. Yeah, it looks
So we're
like
gonna have to go a
26.
little distal and come back, huh?
Yeah, as long as you cover the proximal part, I think it's okay. And that's where the most of the restenosis. I think the distal part of the stent looked pretty reasonable.
But now we beat it up pretty good, though.
It's fine. I mean,
But
you can
not
always put a
distally, though, more
DES distally.
proximally.
You can always put an extra DES distally. It's totally okay.
Wow. I mean, it'll
The
go.
worry is you don't want to strip this stuff, guys. That's why I'm so scared. I mean, you like that? Or do you want to come back? Or you want to go a
No,
little...
I would probably stay there, just pull back the guideliner and then pull back if necessary.
No, but the question I'm saying is,
The length?
where do you want the...
You want to change the angulation and take a picture and see? Because you're
Remember
out of the ostium anyway, so you might want to take a picture
So the
and
lesion, if you
angulate
look
it.
at the first lesion, was not really the ostium. It was more like 2 millimeters in from the ostium. So I think if we keep
Okay,
it
let's
right
take a
here.
picture, guys.
Yeah.
Mm-hmm.
The other angle?
I think I like.
Let me see the other picture.
Let's go back to the first.
Let's see this picture. Yeah, so
Yeah,
there's no
this
lesion
one.
distal. It's in the stent. We just got to cover the stent.
Correct.
Yeah,
That's what I'm saying.
Let's just cover the stent.
It's just
And the
mainly in
ostium.
stent.
So
Yep, I'm going to come back.
Yeah.
Yeah, because all the deformation at the proximal edges.
And I think the stent is within the.
That's good right there.
That looks
I would
good.
probably
Yeah.
bring back a stud more, PK,
Hold on. One
if
second.
necessary. I don't think it doesn't matter. It's a huge iota, so
I
it's
think that
okay.
should be good because the lesion wasn't more distal.
No, I like this.
This is bad.
Yeah.
You guys like
That's
it?
good.
We still that is
Alright.
much
Can we
better.
can we mag up a little bit on it?
Sure, sure.
One more.
I'm sorry. Probably a stent stud more, don't you think?
Yeah. I think
See
because the
see
stent
there's
is
a-
still there. You have to pull back a touch more
Just so you can
A
cover
stud
all
more.
of it,
Yeah, that's a good spot.
because the
Probably,
stent
yeah.
comes out.
All right, go up.
Right
You're
there.
hanging.
Go up.
Yeah.
This is good?
Hold on.
There's a little
Go
bit
up.
of negative tension there.
Yeah. I think that's good. It should cover.
No
yeah.
die.
No, I'm not gonna give that.
Perfect.
To pull your
That's
guy
really
back.
good.
Otherwise, it's gonna
Or-
push everything. Yeah.
I would not pull the guide more.
I
the
know,
stent
I know.
might-
No,
the-
no,
the-
but-
the stent, yeah,
Exactly.
I know.
That's why I
You want,
didn't.
to keep, you want to go higher?
Yeah, go
It's
to
at the
stent
normal.
might get pulled up.
What is good? What is it? Go 6. Make it a 6.
6. Go.
Okay, 4, 12.
Huh?
What
What do you at, guys?
14, 12.
12, I meant 12.
Okay,
The
14.
rated burst is
14.
14.
Yeah, down.
Down.
Go up again.
Now we can go. Go 16.
Good.
And good.
And then probably
Okay.
pull back and then go up again.
Yeah, but let me just engage.
Yeah, I mean the reason was the balloon was going into the brain, so I don't want the stent to compress on itself. That's why we wanted to pull the guide back a little bit to give room for the balloon. But I think now it's good.
I would balloon there. Yeah.
I know. And then we'll track our guide.
Okay, go up now.
It's a good spot. I like that stent, the way it's placed. Couple of stent
Yeah.
studs out.
Pull
Okay,
at
down.
10, 12. Good. That's enough. Let it come, let it come.
Okay.
Compresses. Yeah.
Good.
Yeah.
PK, do you really want to
Oh, okay.
engage it? I don't
No, I
think
don't
it's
want to
necessary
engage
to
it.
be engaged.
Yeah.
It. Yeah. I would
Just a
probably
little
just
bit.
leave it. Yeah.
No, come up closer.
All right.
Okay.
Let's take this out first.
Yeah.
I mean, it's a papyrus stent. It's not like a VBX. I mean, it might get compressed. So might want to just leave it. I think we got it.
Uh-huh. Well, the guideline is all the way back anyway.
Mm-hmm. Give us an IVUS, guys.
Let's take a picture.
Mm-hmm.
Take over 8 now.
No, whatever we have. 014 is fine. Let's take
Yeah,
a
both.
picture. PK.
Okay.
We
The
have
other
to take a
angle
picture.
probably is better.
Yeah, a little bit more of an Mario or something.
Yeah.
Open
So that you
Go.
can take the overlap out.
Ready?
Yeah.
Mhm.
I like it. Looks nice.
Nope, that's just an aortic shot.
I like the REO 19 better than this. There's so much overlap on it.
So go to REO 19.
Yeah.
Okay, let's try this.
Much
Mm.
better.
Is that just filling? Is just our
I
filling?
think it's
Yeah.
just filling.
Same
Okay.
Yeah.
IVUS.
IVUS?
We'll go up. Yeah, IVUS, and then we'll go 7 per 14.
What about that distal lesion? I'm just gonna
Yeah,
leave
Yeah.
I don't know.
it. That was
I
like
don't know
that
if it's
before.
real.
I mean, if
Yeah,
you IVUS
exactly.
it, we'll know, PK. So I think it's fine.
Yeah.
IVUS will give
I
us
think
an
it's just
answer.
a
so-
feeling. Yeah, it's just probably a
I-
feeling.
Yeah, but I do think, like, after all this work we put in, I think doing whatever we can with the contrast,
Okay.
volume and PSI to really get
Can
a
you go?
full opacification.
Yeah, I'm gonna get you a
agree.
better picture.
Agree
I
with
know.
that.
After all this work, I mean, you
Agree with that.
need to be able to sleep peacefully at night.
Oh, IVUS is gonna tell you whether it's opposed. That's for sure.
Yeah. Let me put that wire.
As we slowly approach the conclusion of this case, let's talk about what we always talk about. What's medical therapy?
Yeah, medical
What do
therapy.
we do for her now?
Atul, what do you think? What would you keep the patient on?
Everything possible.
Everything possible.
I
Whatever
tend to
she can
agree.
tolerate. I mean, she's
Yeah.
88, if I remember correctly.
Oh.
Her bleeding risk is
How
high,
did it disconnect?
IVUS?
It got
clearly
disconnected,
down.
Asif.
for sure. And I think the question is, rivaroxaban 2.5 80 or not. No data, of course, in these cases.
connected.
She has no other indication for anticoagulation, right, Twinkle?
What's going on with my
No,
IVUS?
not really.
So I mean, I think at 88 years old, I would use
Oh, there,
aspirin
we got
plasma.
it.
I would probably use a rivaroxaban for the stent and not a.
No, don't go more. That's it.
You know, I guess
IVUS is on, guys.
IVUS is on.
IVUS is
Start
on.
recording.
I
Can you see the IVUS, guys?
Yeah.
Mhm.
Can we
Okay.
adjust the image a little bit, or is it you
Very
you
live.
think
It's
you
not
guys are
recording
okay?
yet.
Yeah, it's an 014
We can see it
IVUS.
really well.
Oh,
Can you
okay.
adjust the camera
Increase
image?
the gain, I guess, for them.
You got to increase it actually.
Increase the gain. What is this? Not. It's right outside the stent.
Correct. It's just
Oh.
the other way then. That's good.
Okay. Let's start.
Well, stent
recording
is
here.
stent is definitely well expanded.
Record, please. I think the catheter itself.
Okay. Okay, give me another IVUS catheter, guys.
014, yeah.
Passport might have got damaged with the bends and everything. So
Mm-hmm.
Yeah. I think the angulation, the bend, and everything.
So the first vote was for Xarelto 2.5 along with aspirin.
Give me-
Plavix or
All three?
triple therapy, or what do you think?
I think I would go triple therapy for the short term. At least short term meaning at least 30
Sure.
days. Assuming there's no history of bleeding, the bleeding risk is on the lower side.
Yeah.
But what is the
Let's-
why,
there's
why,
no
do,
data.
why do you?
Yeah, I don't.
But
see
why
the
do you
value.
guys say triple therapy? I don't understand because you've got a high flow state here in the mesentery, right?
Yeah.
The thrombotic risk is kind of low because of the flow status. I think here you should just basically do dual antiplatelet and
Correct.
for a month, or if you want to be really aggressive, 3 months, and then go back to aspirin and follow her clinically. That's all you can really do.
I mean, that's a good point. But remember, this presentation is chronic mesenteric ischemia, not acute thrombotic. So if it was an acute thrombotic, maybe an anticoagulation, again, off-label, no data, triple therapy. But if it's a chronic mesenteric ischemia with restenosis,
Overshow.
yeah, I think
That's
it's a
what I would do. I would probably.
There's zero data here. You have 2 layers of stent, and then you put a covered stent on top of it, and you put a
Yeah.
papyrus in an area that doesn't normally get papyrus. So
That's
I
true.
think the data is not really. It's all theoretical now as to what our judgment call is in the case.
Yeah.
Yeah,
And
but
you guys know the system very well.
But until
So you don't
she's
have that call.
she's almost 90, right? And you've got definitely a high risk of bleeding if you put her on three agents. So I definitely would not put her on 3. I just think that in this case, high flow state in the mesentery, 2 is more than enough. I think she'll be fine.
Yeah, I mean, I was
Real?
Yeah.
I was thinking more about like how can we up her, her anti her cholesterol lowering regimen? Like, would she be somebody who you would really push to put on Repatha and go down that uphill battle of getting on a PCSK9 antagonist? Considering this is her now 3rd intervention.
I don't think her restenosis. You think it's because of the
Okay, guys, I'm going to
hypercapnia?
go from proximal to distal. Here's
Yeah.
the proximal stent, well expanded. Agreed?
Yeah.
Okay, I'm going now distal.
That's your 1, 2, 3. Actually,
Okay,
3
recording.
layers, you
Everything
can see.
looks really good here. Looking really good. Looking good. Looking good. It's like, the IVUS is like the worst part of this case. So right now this is distal,
That's distal.
Looks good.
right? And that's not so bad at
Did we
all.
record?
Okay.
No, that was not recorded.
Yep. Now I'm going to go back. I'm going
Guys.
to pull back. I'm going all the way down now.
Code bhai,
And that's the
code.
bifurcation, and that's the area we thought was stenotic, and it's really not. So record, guys. So I'm going to do a pullback, IVUS pullback. See, that's the stenotic area right there. You saw it? That's not really that bad. I'm going to leave that.
No, yeah, we'll
And
leave
then
that
I'm going to
without running.
come. And really just the distal edge is what I really want to look at. There's my distal edge. Looks pretty good.
Looks very good.
Entering into the stent.
That's your first.
There's
layer.
my stent. That's my covered stent. So whenever we
Correct.
didn't cover the distal edge with the covered stent. And then the stent is pretty well expanded, but I don't know if it's a 5.
We'll measure it.
And we're out of the vessel.
Perfect.
Okay.
I think at least the proximal end looks like it's a 5. Okay.
So are we going to go crazy and do more, or we stop?
You can stop, guys. Recording.
What do you guys think?
Oh, from the balloon? Let's
Let's-
see
let's-
what the luminal area looks.
Question is, we need to get a better picture like Raman said. So let me see if I can get the guideliner in.
Take a picture through the guideliner.
Nope,
The
doesn't
previous
wanna go.
stent is a 4-0 stent, right, Twinkle?
5-0.
5-0.
Five. Yeah,
5-0.
I think
I would probably take a 5-0
go
balloon.
5-0 balloon
Yeah.
and go
I would take a
real
5-0
high
balloon,
pressure.
short balloon, 5-0.
5-8.
Yeah.
Go
And then go and
crank it,
just do the distal edge as well as the whole stent.
crank it up to
All right,
base.
give us a 5-0 balloon now.
Use the same balloon.
Yeah.
Give us a new
Again, I also
5-0
think
balloon, guys.
I would try to keep the guide liner and guide out of that stent so that it's just a freshly
Yeah.
placed covered stent, and just you don't want to.
I'm just putting the guide liner there just to be able to
5-0.
Yeah,
engage.
I think
Give me a new balloon. New balloon.
Yeah.
it's much safer to put a
Give me a
guide
new
liner than
balloon.
to put a
I
guide
want a
liner.
5-0 new balloon.
Yeah, I mean, technically here, if you're really concerned, you can also take a picture through the guide liner. So just decrease your pressure a little bit if like corneas, and that might give you a better picture.
So let's
Rather
take a
than
picture
all the
through the
guide.
guide liner. Ready?
Yeah, hold on. Let me do 5 for 10. Yeah.
Yeah.
Okay, ready.
Ready?
Yeah, but now it's going to go all the way down, but it's okay. Go.
Should have some
Pull back a
backflow.
little bit. Yeah, we'll have some backflow.
Yeah, I know. See, now we have backflow, so now you can really see.
Mm.
The distal looks nice, guys. I'm not worried about
No,
that.
no, it's okay.
I'm just
We
gonna
did the
I'm just gonna
iris on it.
balloon it like you said with a 5, and then I'm gonna pull the guide liner back and take another picture, and we're done. Woo! Mesenteric ischemia.
He gave you arm
So next
ischemia.
time we're gonna go with brachial cut down.
No, I think this is a really nice catheter for the cardiologist to know. I mean, the radiologists and the vascular surgeons who do a lot of
What the hell?
aortas definitely know this catheter. But you can see here the difficulty
I
we
mean, the
had.
EP guys use a lot of steerable catheters, so
Right.
and steerable guides to get into the CS.
Get another
so
5-0? Why is the tip broken?
they're used to it already, but they don't put any
Okay.
things into the CS, so they they don't put like huge stents into the CS, so for them it's much easy to manage it. So
Yeah, but I mean, I think in this case, I think it was very nicely done here.
Yeah,
we
agreed.
had a nice
it's a nice
It's not-
demonstration of this.
this catheter and
Yeah.
dealing with this particular thing. But like I said, we're very responsible with the wire so far. With Vishal, you never know. You guys know that. And so we have to make sure that
Vishal is making sure the wire is not coming under your boots.
right. That's the key. Ready? So I'm gonna now walk out the guideline. If Vishal is okay with this, I think we're good with this, right, Vishal?
Yes.
Yeah,
I think
go
it's
up,
good.
guys.
Perfect. Hold on. That's fine. We're good. Go up. Slowly.
Just go to nominal.
Atul, I just want to let you know, if somebody even sneezes outside the room, it's still Vishal's fault. So
That's good.
during the live case.
Okay.
12.
So,
12.
Yeah.
Okay. We're just dilating this nominally.
Thank you, Karthik.
So
that's how it is, Vishal. If I'm
I
in the room,
know.
it's my fault. If you're in the room, it's your fault.
how come I never blame
12.
Raman? 12.
Hey, if Raman is in the room, it's PK's fault, actually.
Yeah, that's true. I was going to say.
Raman is
If
like the
Raman is in
baby
the
of our team, so he's all spoiled.
This logic at all.
Okay, go up here.
It's PK's fault if Raman pulls
Go
the
yeah.
wire. No, it came back. It's okay.
Yeah,
That's
I just
okay.
wanted to
That's
point
okay.
It's
You're
okay.
out of
Yeah,
the
no,
out
no,
in
no.
the
it.
order.
Yeah.
Okay.
I will try to
6.
track it over.
8,
Same
10, 12.
10, 12,
14.
14, 16.
Mhm.
18, yeah.
Boston Scientific.
And then I would take that.
No, it's okay. We just trailed it in, and we are well in the stent now.
Yeah, let's take a nice, let me walk this out, and we'll take a nice picture. Hold it.
Yeah.
Guideline is out too. That's okay. Let me just go posterior. Oop. Okay, good.
That's
Ready?
it. Yeah.
Okay.
Me and Raman are having like palpitations here.
I know. Me too.
We're not in the vessel.
PK,
the
I would just leave the guide liner there at the tip
That's what I was.
Mhm.
and take the guide out, the whole tour guide out,
Yep.
and take pictures
Mhm.
through the guide liner. It's easy.
I agree. I agree with you.
Yeah, just much easy to deal with it. It's softer also on the stent
Give me the guide liner back.
because one more
I know.
time,
I saw that. I'm like,
one more time you put that tour guide there, Raman is going to walk out of here, come there and take it
We
out.
need a new one.
we don't need a bullet.
Raman's chair is going back and back and back every single time you put that tour guide into that stent, you know.
I know. Right now,
Raman is holding Karthik's arm right now, and Karthik's arm is bruised.
well, we're almost done here. So let me just take a final picture, and then we'll be done with
Yeah.
it. it was so much easier to take a picture from the arm. We're so coaxial.
No, but listen, it's all about good learning case and just trying to do alternate strategy and various steps. Sometimes it's not easy, but it's all about being more careful and more cognizant of the fact that you don't end up ruining what you already have. And now we are chasing our own tail, and now we have a destroyed stent and all this stuff. So it's one of those techniques you have to do.
To echo that, I mean, it really does go back to our pretty
That's
consistent
good.
teaching.
I think it's
that it's really important to know what's in your inventory. You gotta know what you have,
Yeah.
what you can work with, what you can't work with.
I
Just
don't
leave
think
it
I'm
at
in.
So you can see, how can you navigate,
I can get you a balloon down and take the
difficult
guideline over.
access
Give me that
choice,
same balloon.
device choice.
Hold on.
in
Let me get
complex
you a good
cases.
picture. Hold on, PK. Don't do anything to the stent. We'll do the same guideline. It's okay. One extra step.
I'm through. Okay, ready?
Okay.
Okay.
I'm just gonna pull it here.
And on that,
Okay, good.
Good,
Ready?
good.
hold on.
Yeah.
Flo,
Mhm.
1 second. Let me get you one good picture, Flora.
Go to 18 RAO. Okay,
Good.
that's good. Ready?
Perfect. See you all the way.
Good.
Looks very
We know
good.
IVUS-wise it's good. We just want to make sure that the stent is well expanded. I'm just gonna go down below, make sure we have no perf.
And lower man.
The other way.
Ready?
Okay.
Mm-hmm.
Very nice to see the blush.
Very nice. And anything else you guys want to see, or we're done?
no. I think
we're
we're
good.
done. Looks very good.
Done.
Just take one
Wire out.
Yeah, wire out, and then we're done.
Yeah.
Let me first. Actually, we can straighten it with the wire there.
Twinkle, I don't know if this is your last presentation with us, but that was a really great presentation today.
Oh,
I
thank you, Dr.
feel
Kukar.
refreshed from a like anatomy point of view.
Oh, thank you.
Circulation was very well described.
That's it.
I appreciate
Thank
that.
you.
Beautiful.
All right, you guys. So thank you for a
Thanks.
great case. I just want to finish by saying that we'll see you guys all October 6th to 8th. And, we have a great fellows course as well as a great aortic and
The
venous
7th.
course.
We'll close it,
And
huh? You wanna
I
go
think
on?
we'll have
For
a
sure.
wonderful discussion, and we'll do complex cases as we've always done. The live case sites have already been agreed upon, 3 of them. One is Dr. Chris Metzger for the non-aortic side from Tennessee, Dr. Jihad Mustafa, ourselves, and Dr. George Adams. The 4th live case site is still being decided. And for the venous side, Dr. Lookstein, Dr. Patel, and Dr. Fishman are going to do their live cases right from Mount Sinai Cath Lab down below in radiology. Aortic, as you know, is going to be really more like an advanced aortic fellows course, where we're going to have aortic cadavers as well as simulators for demonstration of aortic cases. So, and there will also be an aortic case competition as well as a fellows case competition. So again, we thank you again, and we'll see you guys in the end of June. And I think this may be Twinkle's last case as a live case, because in June she's probably going to be moving on. So I'd like to thank her for all her hard work. Luke will be here, so we'll thank Luke in June. But thank you so much, Twinkle. I know that
thank you.
won't be here in June.
It's been a great year with the fellows.
It's
Yeah.
been a great year,
Yeah.
so we
Really
appreciate all
good
the
year.
hard work you did, and we'll see you in Chicago. So thank
Sounds
you.
great.
All right, guys. Thank you.
Thank
Thanks,
you.
guys.
All right, guys. Thank you very much. Thank you for joining us today. We look forward to welcoming you back again at the end of June on June 29th. Take care and have a good day.
Okay, guys.